My topic is on myocardial protection and ischemic preconditioning. So, myocardial protection usually refers to a set of pharmacological and physiological strategies aimed at attenuating the intensity of ischemia and reperfusion injury during the cardiac surgery and its consequence on the myocardial function. So, it is that the increases the heart's ability to withstand the ischemic insult. So the main goal will be a bloodless field, which can limit the myocardial damage, and they can decrease the intracellular acidosis, edema, and depletion of ATP, and preserve the coronary blood flow, and they can reduce the reperfusion injuries. Coming to the pathophysiology, ischemia of sufficient duration can cause a cell death, but ischemic insult should be interrupted at an appropriate time so the patient will have a viable myocardium while experiencing a sequel of low cardiac output and arrhythmias. So outwriting to cell death, we have a cell death. It can be averted by either a stunning or a state of a hibernation. Some phases of myocardial injury, either it can be a local or a global ischemia. So three phases, which include antecedent ischemia, protected ischemia, and reperfusion injury. Measures against antecedent ischemia is we need to continue the preoperatively or the beta blockers, statins, antiarrhythmic drugs, calcium channel blockers, nitrates, aspirin, and digoxin, everything. And we need to reduce the anxiety levels by giving anxiolytics and suppressing the responses uh, using drugs and also hydrating them. So protected measures against the protected ischemia, which happens during the coronary bypass period, is we can go for a asystole period using cardioplegic solutions, hypothermia, hypocalcemia, left ventricular venting, then intermittent cross clamping with brief periods of reperfusion can be done. Measures against reperfusion injury, like free radical scavenging, IV propofol or sedating the patient. We also can use the potassium channel openers like nicorandil agents. So coming to stunning, myocardial stunning, which is commonly encountered phenomenon, which is characterized by potentially life-threatening and post-ischemic myocardial impairment. After an coronary blood flow has been fully restored, like unstable angina or after aortic cross clamp during the cardiac surgeries. So main mechanism of stunning is either a combination of cytosolic calcium overload or development of oxygen-free radicals will be there. Then about the hibernation, it is a state of persistently impaired myocardium and LV function at rest due to reduced coronary blood flow. This can be partly or completely restored to normal if the myocardial oxygen supply demand ratio is altered by improving the blood flows. Then coming to temperature and hemodynamic modulation, this hypothermia offers a myocardial protection by promoting the electrochemically inactivity, and they can impact the process, which can result in apoptosis and reduce the oxygen consumption. So lowest oxygen demand occurs when the heart is arrested and decompressed. So at the temperature of 22 degrees Celsius, the oxygen consumption is around 0.3 ml per 100 gram per minute. As per the Laplace law, increasing the wall tension can increase the contractility heart rate, which further increases the oxygen demand in myocardium. So we need to aim to reduce the ventricular wall tension. We can do it by venting the left side of the heart by decompressing and removing the air and providing a dry operative field. We also can use a cardioplegic solutions, which are also protective. And coming to ischemic preconditioning, so ischemic injury is something like tissue or cellular injury occurs as a result of interruption of a vital substrate. Reperfusion injury is occurs after a reintroduction of a vital substrate after interrupting interruption in supply, preferably oxygen. So coming to preconditioning, which defines as changes at the biomolecular level that enables the specialized tissues to tolerate a major adverse or ischemic events better if these tissues have been already exposed to several minor adverse ischemic agents. This can be two types, early and late. Early ischemic preconditioning, it starts within 15 minutes, lasts for several hours, and protects against only myocardial infarction, not against the myocardial stunning. But in the late ischemic preconditioning, it is a delayed window period of protection which starts after 12 hours and it lasts for 4 days. It gives protection to both myocardial stunning and myocardial infarction. So this preconditioning event, it can occur in 3 occasions when the myocardium is subjected to insult before, before insult or during insult or after insult, and hence the name preconditioning, periconditioning, and postconditioning. Regardless of time, there are some phases like early phase, there occurs a cellular signaling and the cascade of amplifications inside the cell, which leads to immediate cardioprotection. In later phases, there will be a genetic reprogramming that offer a sustained cardioprotection. So the mechanism, it includes receptor activation, which is done by halogenated volatiles, opiates, adenosine, beta blockers, and dicnogen. Then intracellular signals like phosphatidylinositol 3 kinase, protein kinase, triggered mechanisms, mostly by the volatiles what we give, and then reactive oxygen species and nitric oxide synthase. They all act at the intracellular signaling cascades and enhance the preconditioning effect of the volatiles. And further, there are mitochondrial effectors. The components like potassium ATP channels and mitochondrial permeability transport proteins, transport force. They all act as a very important components. Their modulation can help in the preconditioning. So few drugs which can open the potassium ATP channels like Myocardial, pinacidal, diazoxide also help in the preconditioning. Um, then modulation of the calcium homeostasis can be done. So lesser the calcium uptake, better the preserved mitochondrial respiration and ATP synthesis. Then we have a improved effect on the vascular wall. And concurrent hypothesis like hormonal, cytokinin, immunological, and cellular activity, they're also implicated in the preconditioning. Immunologically, like less pulmonary neutrophil accumulation after preconditioning of volatiles. Then metabolically, we can tell like preconditioning, they enhances the ATP preservation by reducing in energy consumption and metabolic downregulation and slows down the apoptosis. Then further, it leads to a genetic transcription and expression. This is all facilitated only by the receptor activation. So mainly, who's benefited? Uh, uh, Patients who benefit from preconditioning, like extreme cardiovascular disease patients with poor collaterals, severe LVH with reduced subendocardial perfusion, the patients with anticipated prolonged ischemia time, then patients with senescent myocardium, which are who are prone to tissue damage from the calcium overload. So the effect can be seen like clinically we can see a reduced myocardial infarction incidence and reduced inotrope requirement, reduced ventilation time, and thus reducing the hospital stay. Biochemically, they come down on the cardio biomarkers like tropoid BNP, CKMB levels, and the myocardial lactate levels, and even the free radicals level also. In monitoring level, like cardio bring an echo, we can visualize a reduction in the wall echinosis, better LV function, improved oxygen utilization can be seen. Uh, and then there is a term called anesthetic preconditioning, like similar to ischemic preconditioning, which is exposure of myocardium to halogenated volatiles in order to reduce the subsequent injury due to ischemia and reperfusion. So as low as 0.25 Mach is protective, but the maximum Mach of 1.5 to 2 is very effective. What does the volatile do is they can reduce the chronotropic, inotropic, and lusiotropic effects and reduce the afterload of the left ventricle and reduce the myocardial oxygen demand and improve the coronary perfusion. They also alter the neutrophil functions. Other components like xenon, adenosine, nicorandil, norepinephrine, and morphine also involved in anesthetic preconditioning. Factors inhibiting preconditioning like aging, diabetes, hypercholesteremia, then the pertussis toxin. Uh, Then other pharmacotherapy like beta blockers, statins, and alpha agonists help in the preconditioning. That's
We have spent more time on ischemic preconditioning, but the first part I think has not been dealt because the myocardial preservation question can also be indirect way of asking about cardioplegia. So just making a simple mention about cardioplegia and the finishing of the answer is not correct. So you have to, it is an indirect way of asking about your, find out your knowledge about cardioplegia and its uses in preserving the myocardial function. So when do you use cardioplegic solutions?
during on-home cardiac surgery.
During open heart surgeries, isn't it? When the
Yes.
blood is diverted from the heart to have a bloodless and a motionless heart to repair the defects in the heart. At that time, there is a perfusion of the heart, which is through the coronary vasculature, is affected. So, in order to reduce the demand of the myocytes and preserve them from going into ischemia and necrosis, that is the main idea of myocardial preservation. So, it is done during cardiopulmonary bypass surgeries. And, you have to write more details about the cardioplegia rather than just making one line mention about it and passing it off. Okay. So
Yes.
I'll just show that thing that you have to write about that.